All right. So good afternoon, everyone. My name is Emily Hirio. I work at a small nonprofit in San Francisco called Project Inform that works to address hepatitis C as well as HIV through information, education, and advocacy. And we coordinate a statewide coalition called the California Hepatitis Alliance, which is a membership organization made up of about 90 groups from around the state working to address hepatitis B and hepatitis C. And I'm pleased to moderate today's webinar on hepatitis C in California and the role of the primary care team. This webinar is sponsored in conjunction with the California Academy of Family Physicians, which has done a lot of the logistical work to make sure that this could happen today, and I thank them for that, as well as the National Viral Hepatitis Roundtable, which is a national organization working to end hepatitis B and hepatitis C. So I'll briefly go through the agenda and then introduce each of our speakers, and we'll get into the meat of today's webinar. So Rachel McLean will talk about hepatitis C in California. Dr. Marshall Kubota will talk about hepatitis C screening recommendations and the role of the primary care provider. Dr. Stacy Truskin will talk about an example of a hepatitis C screening protocol for primary care from Philadelphia. We'll have time for question and answers, a brief mention of the California Hepatitis C Clinician Honor Roll, and then we'll close. For everyone's note, the call is muted. There is a Q&A chat feature. If you have questions, you can type those in, but we will open up for verbal questions and answers after the speakers have completed their presentations. The webinar is also being recorded, and the recording and the slides will be shared with you for your future reference. Our faculty for this call, I'll briefly describe them. We're very honored that they were able and willing to talk on today's webinar. So Rachel McLean is from the State Department of Public Health, and she coordinates efforts around adult viral hepatitis prevention through the STD control branch. She completed her MPH at Johns Hopkins University, and she previously worked on policies affecting incarcerated youth and their families at the Ella Baker Center for Human Rights in California, and on issues affecting people released from prisons and jails at the Council of State Governments Justice Center in New York. She also founded the Drug Overdose Prevention and Education Project in San Francisco, which is an innovative effort to teach people who use drugs and their friends and family about recognizing and responding to overdoses, as well as preventing overdose and preventing death through the use of appropriate response, such as naloxone. Dr. Marshall Kubota is the Regional Medical Director for Partnership Health Plan in Sonoma County. Dr. Kubota completed his medical degree at St. Louis University School of Medicine and did his residency at Sutter Medical Center of Santa Rosa. He served as residency director at the program and medical director for both the North Coast Area AIDS Education and Training Center and Public Health Clinical Services for Sonoma Department of Health Services. And he is the founder of the Sonoma County Center for HIV Prevention and Care. And Dr. Stacy Truskin is assistant professor in the Division of Infectious Diseases and HIV Medicine at Drexel University College of Medicine and co-chair of Hepatitis C Allies of Philadelphia. Dr. Truskin completed her medical degree at UMDNJ Robert Wood Johnson School of Medicine, her PhD in public health at their School of Public Health, and her MPH at Yale School of Epidemiology and Public Health. And she specializes in infectious diseases, HIV medicine, HIV hepatitis C co-infection, and internal medicine. These are our disclosures. We'll give you a moment to look at those. Next slide. And then just to note that the California Academy of Family Physicians is accredited by the Accreditation Council for Continuing Medical Education to sponsor CME activities. And this activity is a 1.5 AMA PRA Category 1 CME credits. Okay, so without further ado, I'll hand it over to Ms. McLean, who will talk about hepatitis C in California.
Thank you, Emily. Can you hear me?
Yes.
Great. So thank you for the opportunity to speak with all of you today. As Emily said, I'm Rachel McLean. I'm the Viral Hepatitis Prevention Coordinator at the California Department of Public Health, and I'll be talking about hepatitis C in California. And unfortunately, I can't see the slide. So next slide that says hepatitis C infection in the United States.
It's up.
Hepatitis C is a leading cause of liver disease, liver cancer, and liver transplantations in the U.S. and affects somewhere between 3 and 5 million people. We estimate that about 600,000 to 750,000 people are living with chronic hepatitis C infection in California, but we don't know for sure the true number due to the limitations of our prevalence data. National estimates suggest that approximately half of people with hepatitis C are unaware of their infection. Again, I don't think we really know what the true proportion is for California. I'll be talking about that a little bit more. And as you may have seen in the news recently, hepatitis C is responsible for more deaths than most other reportable diseases combined in the U.S. Next slide. So historically, hepatitis C was in the blood supply for many years and is responsible for much of the prevalence of chronic hepatitis C infection, particularly among people born between 1945 and 1965, which have the highest prevalence of hepatitis C on the population level. And in the early 90s, the first serologic test for hepatitis C was developed, for hepatitis C antibody was developed. And after the blood supply started being screened for hepatitis C, we saw a very large drop in new cases of acute hepatitis C infection due to screening of the blood supply. So nowadays, if you go to the next slide, most new infections are attributable to injection drug use. But there are also a significant number of infections that we see people who don't know how they got infected. We have responded to a number of healthcare-associated outbreaks in the last several years in California from clinicians who are reusing syringes, for example, or not following proper infection control techniques. We've also gotten reports of sexual transmission of hepatitis C among people with HIV. For whatever reason, hepatitis C does not appear to be sexually transmitted very effectively in people that are mono-infected with hepatitis C, but co-infection with HIV facilitates sexual transmission of hepatitis C. Next slide. So as you can see, in more recent years, the incidence of acute hepatitis C has increased in the U.S., particularly among young people. There have been large increases among 20 to 29-year-olds nationally in just the last 5 years. A lot of this is related to the increase in opioid use, in particular young people using oral prescription opioids such as OxyContin, and then transitioning to injection of either pills or drugs that are cheaper to obtain, such as heroin. We have not seen as drastic an increase in acute infections in California as has been seen nationally, but we also know from some studies that have been done in Boston, for example, and other places that acute hepatitis C is very often not detected because people are usually asymptomatic, and also because the symptoms of hepatitis, when they do occur, may not be responded to by someone who's an active young injection drug user who may just think that they have the flu or may not feel comfortable accessing care. So next slide.
Yes. No, I think that's
So as is shown on the next slide, hepatitis C mortality since 2007, the number of hepatitis C related deaths in the US has outnumbered those due to HIV, and this continues to increase in recent years, particularly because a lot of the people, as was shown on an earlier slide, who were infected with hepatitis C through the blood supply in the 60s, 70s, and 80s have had, 20, 30 years for their liver damage to accrue, and we're starting to see people dying of hepatitis C in their 50s. And so these rates of death are only increasing. On the next slide, one of my colleagues at the California Department of Public Health did an analysis of data from the Office of Statewide Health Policy and Development, which maintains data on all the hospitalizations in California. And we did an analysis of hospitalizations from 2002 to 2011, stratified by age group. So as I mentioned, persons born between 1945 and 1965 have a high prevalence of hepatitis C, and for that reason, the U.S. Centers for Disease Control recommends that each person in that age group be tested at least once for hepatitis C, which I think some of the other presenters will be talking about. So we wanted to look at what the morbidity was in that age cohort compared to other cohorts, birth cohorts, in terms of the complications that may be related to hepatitis B or hepatitis C infection. And what we found is that over the last 10 years, hepatic decompensation, liver cancer, liver transplantation, and liver-related and hepatitis-related deaths have all increased over the last 10 years among people with hepatitis C or people with hepatitis B and hepatitis C co-infection. So what this to me really communicates is that the consequences of hepatitis C are very real and are increasing as people age, and that there's a need for screening and detection in this age group. So if you look at the next slide, this just shows a little bit what I was saying in terms of we don't really know the true number of people who are living with hepatitis C in California. As of 2013, which is our most recent data go through 2013, we have had approximately 550,000 chronic hepatitis C cases reported in California. We are currently in the process of conducting a match with our chronic hepatitis C registry to our death records. So at this time, these cumulative cases include both persons who are living and persons who are deceased. We are in the process of doing an analysis to determine how many people are known to be living with chronic hepatitis C in California. But if you look at the estimates from the first slide, we estimate there are approximately 600,000 to 750,000 people living with hepatitis C in California. That's just based on national estimates and the proportion of the U.S. population that lives in California. So we estimate that there are probably another 150 to 200,000 people in California who are unaware of their infection, and that's just prevalent cases there. That doesn't account for ongoing transmission and new cases among young injection drug users. Next slide, please. So if we look at the distribution of hepatitis C in California, we see that the rate of newly reported chronic hepatitis C cases is really concentrated in the northern counties of California, where the rates are the highest. They're also high in some areas in Southern California and some in the Central Valley, but really we see that the northern counties have the highest rates pretty consistently of chronic hepatitis C. And we think that may be to areas of California where the economy is really centered around drug use, and also there are a number of jurisdictions in California that have high rates of hepatitis C, but that do not have any access to sterile syringe programs, such as syringe exchange programs that are effective in preventing hepatitis C when used in combination with other modalities such as medication-assisted treatment and hepatitis C treatment. Next slide. So if we look at the race ethnicity breakdown of chronic hepatitis C infections in California as they compare to the general population of our state, we see that there are 3 groups that are disproportionately affected by chronic hepatitis C infections. Those include American Indians and Alaska Natives, who have about twice the proportion of cases compared to the general population, African Americans, and whites. So Latinos and Asians and Pacific Islanders are underrepresented, whereas these other groups are overrepresented when compared to the general population of California. And I think one of the reasons for that might be that some of these groups have disproportionately had less access to care. And also specifically, one theory that I have at least is that African Americans are more likely to be profiled by the police in terms of search and seizure and may feel less comfortable carrying sterile injection equipment among African American injectors than people of other groups. There's some data from Philadelphia that did a study of pharmacy syringe sales and found that even when sterile syringes are available, African Americans were less likely to feel comfortable carrying them because they were stopped and searched by police more often than other groups. So we think this is just a theory based on that data from other jurisdictions, but we think that may be responsible for some of the disparities that we see here in California. So on the next slide, we look at the distribution both by age and by sex of chronic hepatitis C cases in California. And what we find is a little concerning. So if you look on the left, we show the age distribution in 2009, and what we found was, which is really what we expected, which is there's a large bolus of cases of persons 40 to about 65 years of age, and that is consistent with the baby boomer generation of folks who were infected through the blood supply before hepatitis C virus had been identified. But if you look at the slide at the right side for 2013, we're starting to see a much more bimodal distribution. So we're seeing more newly reported cases in young people, both in males and females, and in particular, we're concerned about hepatitis C infections in women of childbearing age, because as you can see, there are some cases of perinatal transmission of hepatitis C from mother to child. Unlike for HIV or hepatitis B, there is no current intervention for pregnant women to prevent transmission from mother to child. Women of childbearing age who are not yet pregnant can be treated for hepatitis C and cured before they become pregnant. But right now, there are clinical trials, I think, going on for children, but I'm not aware of any hepatitis C drugs that are FDA approved for treatment during pregnancy. So we really are concerned about increases of hepatitis C in this age group. So if you look at the next slide, we see that in most age groups, the rate of newly reported cases is decreasing, both for males and females, except for young people, the rate is fairly consistent. It increased 1 to 2% from 2009 to 2013. But there's an exception to that on the next slide. You'll see that among people who are incarcerated in state prisons, which we pulled out as to do a sub-analysis of this population because we know that the prevalence of hepatitis C is very high in the prisons, we've seen an increase of 26% of the rate of newly reported cases of chronic hepatitis C among 18 to 24-year-old males in state prisons from 2009 to 2013. And one of the things that we're looking into is whether this might be indicative of a larger trend that we're just not detecting in the community because people aren't getting tested. There's a fair amount of hepatitis C testing that happens in the prisons, and we think that, or we theorize at least, that our prisons may be serving as a sentinel surveillance system to detect hepatitis C among young people who, if you can imagine, start using OxyContin. Some very small proportion of them transition to injecting pills such as OxyContin and or street drugs such as heroin. And, you know, if people start using heroin and they're out in the mix, they're more likely to be under criminal justice surveillance and be arrested and go to jail or prison. And so we think that this Sentinel surveillance system is sort of detecting some of that trend in our state prisons that we're not seeing in the community. And we're very concerned about that. And there's a real need for testing and prevention of hepatitis C among this age group, as well as prevention of overdose, which Emily was mentioning earlier. Next slide. So I'll just wrap up by saying that, you know, in 2013, we had a meeting of providers from across the state to ask about barriers to screening for hepatitis C, both for baby boomers, for young injection drug users, which as you've seen from our data, are really some of the populations that we're the most concerned about. And what we heard loud and clear was that there was this real perception that primary care providers felt like they didn't feel comfortable screening for hepatitis C unless they could treat it. And so we have been collaborating with UCSF on an initiative called Project ECHO, through which one of their transplant hepatologists, Dr. Nora Turow, provides mentoring and training to primary care providers, particularly in rural and medically underserved areas, to increase their comfort and skills in clinically managing and treating both hepatitis C, but also cirrhosis and other liver complications. We also have a toolkit on our website, and there's a link there that has billing and diagnostic codes for screening and clinical management of hepatitis C. So I'll leave it there, and I'm happy to answer questions during the question and answer session. Thank you.
Thank you, Rachel. You know, there was one question for you in the chat feature, so maybe since there's only one, we could have you answer it now, and then if there's more questions later, people can ask you during the verbal Q&A. There's a question around, is the decrease due to the early release programs? So I assume that's in reference to the folks in state prison.
Well, there's a decrease statewide in newly reported cases, but we're seeing an increase in cases of newly reported hepatitis C among young people in state prisons. And so there, you know, it may be true that overall the population in state prisons has decreased by, I think, something like 20,000 from 2011 to 2013, but these are rates as opposed to just numbers. So each year we account for the population that's in the state prisons, if that makes sense. So it's the number of cases divided by the number of people in the prison times 100,000. And so we've accounted for the change in the prison population when we calculated our rates. I don't know if that answers the question.
That sounded good to me. We'll see if the participant can, if it didn't, they can ask later. Oh, great, they said yes. All right, perfect. So we will move on to our next presentation. Thank you, Rachel, to Dr. Marshall Kubota to talk about the role of primary care providers in hepatitis C screening, diagnosis, and care.
Good afternoon, everybody, and I hope you can hear me. If you can't, somebody just message us, please. I'm pleased to be here today to talk about the role of primary care providers in hepatitis C. And I think as treatments have gotten better and easier, that this is a important role for our clinicians, as I think when it comes to hepatitis C with lower levels of or without advanced liver disease, that indeed it becomes something that primary care clinicians can do if they're well prepared to do so. I am a family physician. I'm in the overall position of having treated hepatitis B and C for many years, as well as primary care medicine and HIV. And my other role as a medical director for a not-for-profit Medi-Cal intermediary that covers 14 counties, including all those very dark-colored counties in Northern California, puts me in an interesting position to see what is happening in our communities and how our clinicians are working. So I'm here to talk about the issue again of screening and a bit about the primary care role in the diagnosis, treatment, and care of people with hepatitis C. The sources of testing guidelines are easily available, all very similar with a little bit of differences from the CDC, the 2015 STD treatment guidelines, as well as the AASLD. The AASLD is always changing as new drugs come out, and in fact, in this month of July, changed twice within a matter of 2 days in their guidelines. But the change was really a matter of an error, I think, in their original publication of July 6th and was corrected on July 8th. But again, the treatment guidelines are very clear and well done. Next slide, please. The CDC recommendations, it's a two-part. It's the test for screening for antibodies, but should be followed by confirmatory testing, knowing that 15%, maybe 20% of individuals with hepatitis C antibodies, meaning they are actually viral negative. They cleared the infection by themselves. And as a sometimes referral source, a consultant source, I have seen people referred to treatment who are antibody positive, who actually have self-resolved the treatment, are viral negative. The HCV RNA testing is negative, which means these individuals have resolved the infection on their own and don't need treatment, although they may need advice because they did, of course, acquire the infection to begin with. But that's really well done within the primary care setting for those individuals who are antibody positive but viral RNA negative. An important thing, and again, in the rather important scarcity, sometimes in some situations of the utilization of our specialists, we should take several steps ahead in preparation, and I'll get into that, of our patients if we are going to refer to specialists. There is a window period for antibody formation, but understanding that oftentimes we're testing people for a distant possibility of infection that is not an active factor in our testing, the window period, but it may be in different circumstances. Next slide, please. Baby boomers. Now, this was a blanket recommendation to test. It's included in all the professional guidelines. An easy way to remember this is the last baby boomer turned 50 on December 31st, December of 2015. All our baby boomers are 50 and older at this point. I hate to say I am in that group as well, right smack somewhere in the middle, and it really goes 50 to 70. But our baby boomers are 50 and older at this point in time. So they should be tested once without ascertainment of risk factors. And the reason for this is being they may not know they had a risk. And next slide, please. Actually, I think I get into this a little bit. So this is what they call treatment cascade. And this is by Yahya et al. And it shows where the missing points are in the treatment of hepatitis C. And one can see that once they're in care, and again, this is prior to the newer regimens, but you can see once they're in care, the drop-offs are relatively shallow. But the big drop-off is the first one. And that is that only, it's estimated that only half the individuals with hepatitis C know they have hepatitis C. And this is why the recommendations for some routine screening are out there to shorten that step off, get more people into linkages to treatment, to get treated, to achieve what is in the lower right-hand corner, SVR, or sustained virologic response, which means cure. That is a negative viral load 12 weeks after treatment, and that is a marker of a cure of hepatitis C. So we need to move all those bars upward, but the biggest drop-off is in that first section there, and that's why the emphasis on screening and testing for hepatitis C. Next slide. So the baby boomer testing, the risk ascertainment is not necessary because they may not know their risk. They may not be willing to say their risk. That in 1962 or 1971, one time they shot drugs and shared needles with somebody, and now they're a banker, right? And so they may not divulge that risk. And so the way to do this, and we'll hear from Dr. Trusky on this, is, again, it's blanket testing. There also are oftentimes misconceptions that they think they've been testing. They'll say, well, I was tested, and you ask when? Well, I was tested in 1990. Well, there was no test for hepatitis C in 1990. And so, again, or they think they've been tested. Well, you tested me, didn't you? You know, or somebody tested me, and indeed, because oftentimes they think it's a part of routine testing, and that may not be the case. And of course, they may think that the hepatitis is they turn yellow or something like that. And of course, it may be a very silent infection, both in its acute and chronic phases. We will hear from Dr. Trusky about workflow integration. Now, in California, unlike HIV, there's no special consent needed. It is in the consent for treatment, although, of course, in fairness to patients, they should understand they're being treated for and the reasons for doing so, and it is in their best interest to do so. And it's much easier now to get across the issue of testing because the treatment success rates are so high at this point in time. Workflow integration is a piece of this. You've heard, well, it only takes 5 minutes to do a consent by the clinician. Well, they only have 15 minutes to see the patient anyway. And so pushing that workflow integration earlier in the process, not necessarily done by the clinician, I think is very helpful. Notification processes are also important. There are drop-offs that occur because a patient comes back with a positive antibody test and no follow-up is done of that. And so that notification process, again, to keep those drop-offs and the linkages as flat as possible, important as well. Targeted, you've seen this slide before. I'm going to go ahead and go beyond it. In terms of risk, and the unknown risk is, again, a high portion of this. So next slide. So it is recommended not only for all baby boomers, but anybody who's currently using injection drug use annually, and any past history of injection drug use even once. Now, there are a lot of other medical conditions out there for whom HCV testing is recommended, clotting factors prior to pasteurization, hemodialysis, persistently elevated ALTs. So if we're looking outside the baby boomer, or if you need additional convincing that the baby boomers need to be tested, persistently elevated ALTs is another one of those categories. Now, ALTs will wax and wane in the course of hepatitis C, but again, if you catch it with a single elevated, I would test without confirming that single elevated, because that can waver up and down. Yes, you'll get people who drink, again, with a broad definition of testing and the need for it. I stay very loose in that recommendation for testing. Of course, anybody with an HIV infection should be tested, and annually, again, if there's a greater risk of sexual or, again, drug use risk for getting HCV. It's also, the reverse is also true. HCV testing is an easy way to potentially test for HIV. And then organ transplant recipients, some of them were notified and never did anything about it. And blood banks as well, they may have been notified and not acted upon it. Next slide. Recognized exposures, with exposures, percutaneous or mucosal exposure to known HCV infected blood in children born to women with hepatitis C. Next slide. There are a lot of uncertain testing cases. I have a low threshold for testing for hepatitis C, particularly, again, testing that whole baby boomer population. There are certain types of tissues that are thought to be of low risk in transplantation. Intranasal cocaine or other non-injection drug users. Now, the AASLD recommends it in this group, so there's a little bit of difference in the recommendations. Unregulated tattoos or piercings, again, that's by the AASLD, and it's uncertain in other guidelines. Multiple sexual partners, STDs. the long-term steady sexual partners and hepatitis C positive persons are thought to be at low risk with what they have done to date. If their sexual practices change or otherwise, perhaps so. Again, oftentimes it is one of those for the comfort and security of the sexual partners that you go ahead and test them. And again, much easier to convince or think about testing with the high rate of success of treatment. Next slide, please. It's not recommended routinely for healthcare workers, say for pre-employment, for instance, emergency medical or public safety workers, not routinely recommended for pregnant women at this point in time. And again, just to think a little bit about that, there's a little bit of risk history testing. There's a lot of opt-out HIV testing that's there. And again, combined testing is a simple thing to do. Household contacts, non-sexual, of HCV positive persons, although again, there may be cohort phenomena or grouping phenomena to have some considerations, and of course the general population if not otherwise indicated. Other considerations, again, we really want to reduce that first step off older than 50 for testing of baby boomers, lower the threshold for testing and build it into the electronic record, and we'll hear about that. Now let me talk a little bit about the care and management of people with proven current HCV infection. Now I am not going to go into all the regimens because they are constantly changing, but this is an approach to the issue of treatment and testing. Treatment and care. So there are a lot of ways that primary care clinicians can look at this. They can screen and diagnose, they can advise patients, and they can get baseline data. I think they should all be doing this part. Then they may either choose to refer, they may choose to treat, they may choose to treat based upon the level of complexity of treatment of an individual, uncomplicated, let's say, low degrees of fibrosis or asymptomatic disease, or those with more complex disease, advanced cirrhosis, renal disease and the like. And there's a big role for post-consultation or post-treatment care as well that comes back to the primary care clinician, because the ID, hepatologist, GI doc will likely back out of treatment at that time and care, and I think it's important for us to pick up the ball at that point in time. Next slide, please. So the upside of current treatments is the highly curative regimens. It has changed so much. We're above 90% cure rates in most cases and in most genotypes at this point in time. None of the recommended regimens have interferon at this point in time anymore. So that was always the greatest difficulty, was the use of interferon. None of the AASLD primary recommended regimens contain interferon for simple cases anymore. Some do continue to have ribavirin in the treatment regimen. It's very important for women of childbearing age and their partners because of teratogenicity. With the current treatments, the side effect profile is very low pill counts, as little as 1 pill daily. Short treatment times, 8 to 12 weeks, sometimes a little longer depending on the circumstances. There's a pan-genotypic option that will treat all 6 types of hepatitis C, and so the playing field for treatment of all genotypes has been leveled to a great extent. Now, the other upside, of course, and we've heard about this, is a great public health benefit to reduce the community viral burden. In other words, less hepatitis C in the community, less transmission, fewer new cases. That's been applied in HIV, the HIV community viral load, and can be applied to the public health community viral hepatitis C burden as well. But that's only going to happen if we solve that first and take a close look at that first treatment cascade drop-off. Next slide. The downside of current treatments is that the current recommended regimens are very costly. And so the cost is trending downwards. That's very good to see, but it is a very high cost item to payers and the healthcare system as a whole. Current common 12-week regimens run from $65,000 for 12 weeks to as high as $176,000, and even higher for some more complex regimens where 12 weeks can be $250,000, Some regimens are carried out to 24, and some even longer than that. So the cost is very high, and this puts everybody in a bit of a conundrum in terms of the cost of treatment. High cure, high cost. The highest single pill cost is a little over $1,300 per pill. Now, there's the kind of the cost of the healthcare system side of that cost per pill, but there's also brings to the primary care physician a high responsibility. Somebody out there, one of your patients, is going to have a bottle of 30 pills that is $40,000 worth of pills in a little bottle. So just keep that in mind when we work with our patients. Don't lose these. Don't leave them in the car to cook at 140 degrees. Be very cautious about this. So the relative simplicity versus the high cost, a high degree of clinical responsibility. Payers have put in place patient selection because of the high cost. The state Medi-Cal has a eligibility. It did expand. It went down to stage 2 of liver fibrosis, or higher than stage 2. That was a change. They have allowed a lot of complications or coexisting conditions in there as well. That, for instance, all patients with HIV, hepatitis C by Medi-Cal are eligible for treatment. They took off restrictions regarding active drug use or alcohol. Now, that doesn't mean you should treat individuals in this situation. No, but it allowed that level of decision to come into the primary care office and for clinicians to make those decisions. They do have a limited life expectancy criteria, but it is a year. So if in the clinician's estimation that the patient's going to live longer than a year, they're eligible for treatment for hepatitis C as well. Now, private insurers in other states, their criteria are much more variable, but again, state Medi-Cal, level 2 fibrosis, coexisting conditions, and no other restrictions by and large. So this leaves clinicians in the role, as they should be, of making the patient selection oftentimes. If they meet, for Medi-Cal at least, and many other insurers as well, is the patient prepared for treatment? That's an important consideration. And of course, it does bring into the primary care office ethical decisions. I had a clinician call me the other day saying they have a patient who is eligible for treatment, but is a terrible alcoholic, is in the ER for alcoholism and alcohol-related issues. Frequently, is that patient, should that patient be treated? And I said, well, this is your decision to make. There are things you can do about alcoholism or active drug use. And I think it brings into the primary care role for some of these cases the management issue, particularly the high cost. The other piece of this, of course, the penalty is not only failure of treatment, but the development of resistance. So, and the treatment selection may not be entirely up to the clinician, because different insurers, based on cost and the recommendations, may have preferential medications, all of which, again, are highly effective, some of which may be more pills or longer treatment or more difficult regimens. Next slide. So the consequences of poor treatment decisions, and this is where it comes into the office, may result in viral resistance, more difficult or reduced future treatment options, and there's a high cost to futile treatment or treatment in an individual who fails because we didn't have all the parts in place. There's a dollar cost to that, and these are dollar costs out of our healthcare system. There's logistic failure too, poor management, instruction and treatment with individuals who weren't given the right treatment instructions, pharmaceutical errors, gaps, where the authorizations didn't work right, and there was a gap in the middle of treatment, a small disaster. Lost medications, again, what are insurers going to do about replacing, $20,000, $30,000 worth of medications? Drug interactions. This is, again, in the primary care office. There are drug interactions out there with some of the drugs that may lead to failure. So here are common barriers to hepatitis C treatment. This is out of the AASLD, and I will not go down these, but again, a lot of ways that these treatment barriers may be addressed. Next slide, please. So there's the screen diagnose, advise, give baseline information, and referring to somebody else. and that may be something to do. So you want to confirm the viral load testing of antibodies. You want to know they are currently infected. The advice, chronic latent infection is highly treatable. It is a slow-moving infection in most individuals, which gives you time to do this. It's now, with advanced disease, obviously more urgent, but for many individuals, there is time to set things up properly. Healthier living, of course, for the liver and otherwise, this all makes sense. I've seen clinics that make sure that people have had their colon cancer screening, breast mammography, pap testing, and other things prior to this because, again, it is so disheartening to treat somebody for hepatitis C at high cost only to find out they were harboring colon cancer or something like that. Transmission and testing of others, advice in that regard, and it's about blood transmission, potential sexual transmission, and the like. Injection drug use treatment. You know, we want injection drug use or substance abuse disorder is a medical condition. These individuals deserve to be referred for treatment for the disorder so they do not reacquire. Antibodies do not protect against reacquisition of hepatitis C. And so to see to it that these individuals are lower their risk for reacquisition with treatment. And again, medication review, very important, and advice for the future. There are medications, let's say like amiodarone, that could be problems when given with treatment for hepatitis C. So a good drug interaction as well is important. So this is what I would consider some baseline things to send to your specialist if you decide to refer for treatment, the viral quantitation genotype and ultrasound, and INR, not just the regular chemistries that are done. And INR is needed to calculate a child's Turco-Pugh score, the degree of liver fibrosis in individuals with cirrhosis. There are surrogate tests of fibrosis. The FIB4, the APRI, there are ultrasound can do so, elastometry, of course, biopsy, which is not used very much anymore, and there are several companies with biochemical proprietary algorithms. If they have fibrosis, you want to be able to calculate a child's Pugh score for degree of cirrhosis. Other testing, immunizations that are, if necessary and needed, are important. You can look to the ACIP for that. Medication review, sometimes there are specialized tests, cryoglobulins and the like that may be needed, but you might want to leave those to the referral. Up-to-date preventive care, birth control, pregnancy testing, and a detailed past hepatitis C treatment history, because some of the treatment regimens are very particular about what you use if they've been treated before. And interferon treatment failure is only relapse, rebound, or null response, not because they failed to complete, were lost to follow-up, or couldn't tolerate interferon. That is not actually an interferon treatment failure. And they should all, as of course is the case for our practices in general, should have an advance directive. If you choose to treat, it's really a team issue, and I think we heard about that. It's a commitment to develop a team, education, and we've heard about Project ECHO, protocols, education, reminders follow, because we don't want, this is by and large not a prescribe and forget or treat and go. You really want to have a team effort. I think there are exceptions to this. You have one patient, you know them well, you talk to them about it, and you as a singular clinician say, I'm going to prescribe this to you. This is important to take. I want you to come back for testing. I want you to come back to see how you're doing. Yeah, you can do that. But if you're going to treat a substantial number of individuals, there's a potential for these individuals to get lost in larger systems. And I think at that point, you should develop a team. And supply problems as well. You don't want, you want to have your authorization process to do well. This is amenable to telemedicine. You should know your limitations. We do see casual prescribers sometimes, and we worry about those, or you see prescribers that I think are probably beyond their limits in very severe cases of hepatitis C, where I think perhaps hepatologists or transplant centers really should be doing this. This is not prescribing forget. We're getting there, but I think, again, because of the cost of the medications, the potential of resistance, of the consequences of failure treatment, that at this point in time, it takes a team and a programmed effort to treat hepatitis C. And many of our treaters, in fact, the majority of our treaters in Northern California are family docs, primary care clinicians, and PAs and NPs are doing treatment of hepatitis C in Northern California. There's post-treatment care if you've referred them out or you've treated them. Again, you want to do that 12-week post-treatment proof of cure, that's the SVR. Continued healthy choices for the liver. Yeah, I have unfortunately seen individuals who were very good about not drinking while they had hepatitis C, were treated for hepatitis C, and unfortunately said that this was the go sign for drinking, and has caused them problems. So again, continued healthy choices in general, but certainly specifically for the liver, complete the immunizations, prevention of reinfection, those with more advanced disease, cirrhosis care, either in your office through protocol or team approaches, or in conjunction with specialists as necessary. And they may still have advanced liver disease. They may still have cirrhosis, for which there are prescription contraindications, and most commonly the issue of acetaminophen. Okay, let's see, do I have any more slides? So again, simplified and effective regimens, patient preparation, readiness for treatment, work with your specialists, have them prepped well. Don't just make the diagnosis and send them, because that will generate multiple visits. We can do a lot of the groundwork for our specialists, take the weight off their shoulders, make it easy for them to manage the patient by getting the patient well prepped, and laboratory and imaging that might be necessary prior to that. Highly rewarding. This was so frustrating for many years, but now we have high cure rates very quickly, and it's rewarding for the clinician, the team, and patients as well. Thank you very much.
Thank you, Dr. Kubota. Maybe during the Q&A section, you brought up some very good points around patient readiness and kind of assessment of that and the team-based approach that's required. So perhaps there might be some time for Dr. Truskin and Dr. Kubota and any other clinicians who are on the call who might want to speak to it, to talk about some of the success treating people who inject drugs in terms of that team-based approach and the use of, in some instances, directly observed therapy or patient navigation, and the importance of collaboration with medication-assisted therapies like buprenorphine and methadone, and how those can be supportive of the goal of Hep C cure as well. There's a couple questions, or at least one question in the chat box. We'll make sure to get to that when we do Q&A after Dr. Truskin's presentation. So without further ado, I'll hand it over to Dr. Truskin to talk about the work she's been doing in Philadelphia and one approach to a screening program there. Thank you.
Thank you. So greetings from the other side of the country. I do have one disclosure that wasn't mentioned at the beginning. Much of the work that I'm going to discuss with you is funded by a Gilead Focus Award. And we're really going to be talking today about the component of that project that focuses on primary care testing and integrating CDC guidelines for the birth cohort testing into primary care practices. And what we've really tried to do is encourage reflexive confirmatory testing. Now, reflexive confirmatory testing is within one blood draw, allowing that two-step diagnostic process to happen. So among individuals who have been exposed to hepatitis C, they'll always have antibody present in their blood. In order to figure out if somebody is chronically infected rather than those who have cleared the infection on their own, you must do a confirmatory PCR test, whether it's quantitative or qualitative, to find out if there is virus present in the blood. And so when that two-step process is broken down into two different steps, you can lose people along the cascade of care. When somebody is screened using one tube of blood that automatically is tested for RNA in the presence of antibody, you can then, as a provider, call that patient and let them know that they're either chronically infected or not, rather than saying, hey, listen, your antibody was positive, you may or may not be infected with hepatitis C, you got to come back in for another test. So through EMR modifications, provider education, and feedback, we really have tried to integrate that reflexive process into our testing protocols. And then our program also provides linkage to subspecialty care for patients who are chronically infected with HCV. Next slide. Other way. Thanks. So here is exactly that process that I was talking about, that the first step in testing is really that HCV antibody test. And usually if that test is non-reactive, then you can go ahead and stop. You can see on the CDC algorithm that in that stop sign, there's a little asterisk there. And what that was really meant to indicate that if somebody has ongoing risk of infection, whether they're injecting drugs or engaging in high-risk sexual practices, they should be retested accordingly based on their risk. If somebody has a positive HCV antibody, it's reactive, and then you need to go in and look for that HCV RNA. If that HCV RNA is not detected, they have no current infection, but you have to do that additional testing as appropriate. For somebody who continues to inject drugs, you need to continue to test them. Now, once somebody's antibody positive, most times they don't lose that antibody, so that test should be a viral RNA test for rescreening purposes. So I think it's important to consider that. In terms of how we have integrated this testing model into our EMR, we have the Allscripts program for our electronic medical record. And I think that most doctors and other providers have a love-hate relationship with their EMR, and I certainly am no different. Ooh, somebody has really great hold music. This is fantastic.
Yeah,
so
sorry,
I think that's
Jerry,
okay.
is there a way we can mute everybody else besides Stacy, or is that not possible?
Yes, let me look and see. I'll take care of it.
Okay, thank you.
Okay.
Sorry, Stacy.
No problem. At least it's like relaxing and soothing music. So what we've done is we have really instituted 2 prompts. And the first prompt is the patient needs HCV screening. And this is really targeted towards individuals born in the birth cohort that do not either have a prior test result in the EMR for an HCV antibody test, or they don't have any antibody. It's great. I hope you guys can still hear me too. They don't have a prior antibody result in their chart. So we've also gone ahead and put in sort of like a quick order code word. So HCV screen is the way that our providers can pull up our preferred test, which is the HCV screening, which is an antibody test with reflexive confirmation. I should mention that before we even put these prompts in, we went in and we limited access to all duplicate testing options, and we moved all orders for non-preferred tests. And I have to say, when we first went in there were about 60 ways to order a hepatitis C test. Many of them were outdated. So some of you may be familiar with a HCV antibody with reflex to antibody test, which basically just confirms that your first antibody was reactive. It's an unhelpful test. Old outdated tests like the REBA test were removed. And then we also took out the ability to order an antibody test without a reflexive confirmatory test. And that really has sort of ushered our providers into a space of ordering the most effective and one-step option of getting all of the information you need to diagnose a patient. Next slide. The second prompt that we put in, which really tried to get at the patients who had at some point in the past only had an antibody screen but never had the confirmatory test, we basically put in this prompt for all patients who had either an ICD-10 code consistent with chronic viral hepatitis that did not have a PCR test in their chart, or they had an antibody test result present but no PCR test. So they got this testing label. And then we went ahead and put in this HCV confirmatory quick phrase so that individuals can pull up either an HCV PCR quantitative or qualitative test to order. Next slide. So just for those of you who are going to be interested in integrating some of these streamlined testing options into your own programs, we went ahead and put in the preferred HCV screening test is that HCV antibody with reflex to confirmatory testing with both the Quest and the LabCorp test codes there. And you would use this for anyone who's not recently been screened for hepatitis C. One blood draw, it's most effective, and it provides either a viral load or not necessarily a quantitative test result, but a qualitative viral RNA is present or not, if positive, depending on which test code you offer. I should say that LabCorp reflexes to a PCR qualitative test, whereas Quest can be quantitative. The preferred HCV confirmatory test is a PCR test, and those test codes are listed for you there, and you want to use that for anybody who has slipped through the cracks and not gotten a confirmatory test in the past, or for whatever reason has not had a reflexive test ordered the first go around. And if you do order a quantitative test result, it does provide you with a baseline viral load. You have to be careful that the reference lab that you're using, however, is validated to use that quantitative test as a confirmatory test, and currently only Quest has that option, not LabCorp. Next. So this is just a little bit of our data. I'm sorry for those of you who can't tell the difference in those shades of blue. I think when they got reformatted to match the rest, it's a little bit tough to tell. But I will say that the preferred test, which is the diamonds, you can see once we implemented our prompts, the preferred test went from barely being ordered less than 10% all the way almost to 100%, and our non-preferred other tests drop precipitously. So most of the patients within our health system now go ahead and get that reflexive confirmatory test. Next slide. And you can see that the percentage of eligible baby boomers that were tested before and after our prompts went live have increased significantly. Our EMR prompts were added July 2014, and so you can see that some of our practices were testing, most of them were testing less than 10% of the eligible birth cohort. And with the exception of one very, very resistant practice, that's practice number 4, we've been able to significantly increase the percent of eligible baby boomers tested. I have to say that the challenge really with our EMR system is there's no hard stop that prevents a provider from moving forward, and there's no way to kind of pre-populate the order sets for individuals that need to be tested. So the limitations of our EMR really have dictated how this has been implemented by providers, and it's relied a lot on provider education and feedback, which I'll show you a little bit about in a few minutes. But I think for those of you who are listening who have EMRs where you're really able to pre-populate test orders that just need to be approved for providers, and for the patients that need it most, that's going to be your best bet to get to that 100%. But for example, in practice number 2, we've had some really enthusiastic and internal champions that have driven us to getting to where we all hope to be, which is close to 100%. Next slide. So we do provide feedback to our providers in the way of report cards. It's a little bit of Big Brother is watching you and telling you how you're doing compared to your colleagues. But we give a couple of different levels of data to our providers. So this one is just an example of our primary care practice report, and this is often practice level data, so we don't call any providers out specifically, but for example, the lower performing practices have a sense of where they stand compared to other practices within our health system. Next slide. We do also give, though, provider-specific report cards once or twice a year, and we sort of show individuals within their own practice how they're doing compared to others. And so this tends to get a lot of attention and certainly feedback from providers like, hey, I don't think you've counted my numbers right, or I think I'm testing more than this, or wow, I didn't realize I was missing so many. And we try to congratulate and really highlight those providers that are doing a great job. Next slide. And then lastly, we have a newsletter for all of our primary care practices, keeping them updated as to what's happening in the world of hepatitis C. When new drugs are approved, we let them know. If we found issues through our QC process that they need to be aware of, we let them know that too. And next slide. And so just a little bit on our testing outcomes. We've tested almost 7,000 individuals within the birth cohort and other high-risk patients, and we have about a 7.25% seroprevalence, and we do practice in predominantly a Medicaid population in an urban setting. We've had a very high rate of confirmatory testing performed, and of those, we've had many diagnosed with chronic infection, and we've had about a 74% linkage to care rate. We've overall, including our most stubborn practices, increased birth cohort testing from about 3 to 55% of eligible patients. And really, it's been the utilization of reflex confirmatory testing that's been our greatest success. Next slide. A couple of words here on linkage to care coordination. We do have a linkage coordinator that notifies providers of new positive HCV test results in the EMR. It just is a little bit of a prompt to our providers to say, hey, listen, I'm not sure if you've talked with this patient yet, but we get monthly data telling us who's positive. If the provider gives us permission to reach out to the patient, we'll call those patients before scheduled appointments to remind them and after missed appointments. And we aid in appointment scheduling and rescheduling for individuals. Sometimes when you call our practices, they'll tell you there's a three-month wait, but our navigators all have rapid appointments that they can get in within 2 weeks' time. And then we help to identify and address barriers for patients, help them with transportation and other issues. And then if patients are lost to care, we reach out to them, even doing home visits if needed. Next slide. So a couple of lessons learned here. We've learned that there's a lot of hepatitis C in our urban primary care practices, and we've also learned that providers are extremely busy, and it has to be easy for them, and it has to be meaningful. So getting rid of any outdated or less useful tests is important. Encouraging that reflexive confirmatory testing and finding those patients that have been diagnosed in the past but may not have been evaluated for treatment. I think many patients have heard that the treatment is worse than the disease and don't worry about it, or your disease is not that advanced, but that's not the correct message to be putting out there, particularly now that we have a cure. And so providing education to providers and their staff and giving them ongoing feedback is important. And then I think for anyone that's thinking about integrating prompts, you really have to get to know your IT staff and learn what the limitations of your EMR are and what its capacity is. And the more that can be automated, the better. And you have to go back and do that QC all the time because you find things. And the role of the navigator often differs. We run a community-based model as well. And for our clinical model, we find that most of our patients don't need intensive navigation in the home visits we do for our community patients, that sometimes just a referral from the primary care provider is sufficient. Sometimes we give them a little extra help getting a sooner appointment. And then scaling up models is challenging for those of you that work in really huge healthcare systems that would be doing 10,000 tests in a 6-month period or a 4-month period or a 2-month period. Having patient navigation deal with all those test results is challenging, and exactly that perfect ratio of navigator to patient has yet to be determined. Next slide. So a couple of challenges for primary care providers, really prioritizing HCV care among comorbidities. As a primary care provider for my HIV patients, I can recognize that 15 minutes is not enough time to talk about competing health issues. And so explaining to providers why hepatitis C should be important at least one time for a conversation is critical. And then the challenge too of finding those lost to care patients or those who don't follow up with their PCP is hard for not only providers but for navigation staff. There is always insurance limitations, not only with treatment, but also when people lose their insurance, making sure you can provide support. Thanks. And then also, you want to make sure that there's peer-to-peer provider education sessions with all of the primary care providers and their staff. And then always the challenge of EMR systems. And keep an eye on LabCorp and Quest. Somewhere in the middle of all of this, they changed all of their testing numbers, and we had written algorithms specifically with their test numbers along with our IT staff, and all of that needed to be updated when they changed their testing codes. And sometimes they don't let you know when they do that. So you have to maintain a pretty high vigilance when you're writing these complex computer algorithms. And next slide. Just a quick thanks to the See a Difference team. This has been a collective effort by a ton of very enthusiastic students and a really amazing team that runs the program. So just a quick shout out to all of them. And of course to Gilead Sciences for funding the initiative. Thank you.
Thanks, Stacy. So there was one question specifically, I think in regard to your presentation, a question about how many were positive for antibody versus how many were positive for RNA.
Yeah, I think there's a slide. If somebody, whoever is slide meisting here, if they could go back, keep going. Oh, wait, forward. There, stop. Okay, perfect. So thank you so much. So we had 504 antibody positives, and then we had most of them, 442, had RNA tests performed, and of those with RNA tests performed, 362 had RNA positive tests. Does that help?
It sounds like that answers the question, but the participant can let us know if there's more information needed. Thank you.
Yeah, of course.
The other question from the chat box, I think, is sort of going back to something Rachel mentioned, but someone wanted a re-explanation of transmission of Hep C in the presence of HIV. So sort of, I think it's getting at sort of what, the ways people with HIV may be susceptible to Hep C in ways that people without HIV may not be, which I'm sure any of you could speak to.
Well, yeah, this is Dr. Kubota. So the issue with HIV is more a matter of sexual behavior than it is absolute risk as a matter of having HIV and transmission. It certainly appears that HIV accelerates hepatitis C, but not the reverse. Now we have good treatments for control of one and cure of the other, and so again, we hope that these types of concerns or conditions are short-lived in getting people into care. Persons with HIV and multiple sexual partners and multiple STDs should be encouraged to use barrier precautions to prevent the sexual transmission of hepatitis C. Other individuals with hepatitis C, are counseled that the risk of transmission is actually low, particularly monogamous couples where they've been sexually active and discordant for some time, that sexual transmission is low and may not warrant the need for barrier protection. That is not always the most comforting thing to get across for couples counseling. But again, now that we have high-level successful treatment, perhaps that particular need will be less as time goes on.
Hi, this is Rachel. I would just add to that, truthfully, I don't think that this problem is super well understood, like why HIV seems to facilitate sexual transmission of hepatitis C. There's been some examinations, for example, of, HCV virus in the semen of men, HIV-positive men. But I don't think it's super well understood. I mean, we do know that people with HIV who are exposed to hepatitis C are less likely to clear the virus on their own compared to people that don't have HIV. I know there's been pretty strong evidence, at least from what I've seen, that, you know, among HIV positive men who have sex with men, for example, the rates of reinfection for hepatitis C are higher than they are for mono-infected people who have been cured. And I think there's some, you know, there's a biological mechanism involved that I don't think we understand super well, but it is something that has been observed in the literature. And I defer to the clinicians on the line, but that's my understanding just from a epidemiological standpoint.
Thanks.
Dr. Truskin, this is Dr. Kubota. I have a question for you. What have you done with the always confounding and oftentimes not useful Medicare bundled hepatitis panel? I really hate that panel.
Right, yes. So that is an ongoing challenge, and most, I would say that was probably the most common test that was ordered before we tried to do away with it. And so what we did was we took it out of the most common tests that were ordered, and when we went around and had sort of peer-to-peer conversations with the providers, we really urged them to remove it from their favorites list and instead order the appropriate components of what they would need. And many of them agreed to do it, and we've seen a huge decline, but that really was the one test that was most ingrained into providers to use.
And for the listeners on the line, that is a test generally for acute hepatitis A, B, and hepatitis C antibody without reflex, and does not tell you necessarily about a carrier state or chronic infection.
So everyone, just to note, everyone's unmuted now so that you can speak. But if you're not speaking, please mute yourself because there is some background noise. So we'll have the opportunity for some verbal Q&A. But it sounds like someone maybe is outside. Great, I think maybe they muted themselves now. But please, if you're not talking, please mute yourself. There were a couple more questions over the chat function that maybe we can address first, and then we can open it up to verbal Q&A. So there was a question asking, I think you, Dr. Truskin, to describe the process you used for finding patients with a previous antibody test, but no RNA.
Sure. So we basically spend a lot of time with our IT folks, and they wrote an algorithm that essentially looked for the presence of an antibody test result, but no viral RNA present. So this sort of computer language, they wrote it. It screened every single record in the EMR for that antibody test, and then it looked to see if there was viral RNA present in the chart, any test result whatsoever. And if not, then it went ahead and it labeled the chart with that need for screening for confirmatory test.
Thanks. It looks like there's one. The previous question that was asking how many were positive for antibody versus positive for RNA. There's some clarification. Okay, I'm not quite sure what's being asked here. Okay, well, we'll move on and then maybe they can clarify. I think that's all the questions in the chat function. If people have any questions that they'd like to ask verbally, again, you are all unmuted, but if you're not speaking, please try to stay on mute so we minimize background noise. And if you don't want to speak, but you do have a question, you can always put that into the chat box as well.
Hi.
Sounds like someone's ordering lunch, so we might need to mute everyone. Sorry, go ahead.
Yeah, this is Katie Ellis from Highland Hospital. So you were talking about reflex testing and using the same tube of blood to do both the antibody and the viral load. We have run into issues with that in our lab and have to use two separate tubes of blood. Can you just speak, do you know anything more about kind of the lab system that you guys use, or any other more details on that might be helpful?
Sure. So we use Quest and LabCorp as reference laboratories, and which one we use is really dictated by the patient's insurance and where they're capitated to. And so I'm going to tell you that most of the specimen handling requirements are dictated by the reference lab that you're using. And there's even further delineation among each reference lab based on where that blood is processed. So for example, we ran into this issue of when we first implemented reflex confirmatory testing, a lot of our test results were coming back with a note, TNP, test not performed. And we had to do a little QC around why that was happening. And turns out some of our tests were being shipped all the way to California from Philadelphia to be run overnight. And they were not being processed because they were not frozen. Whereas in the LabCorp Quest manual, they just need to be spun down. It didn't really say anything about needing to be frozen. And the tests that were shipped to a reference lab that was part of the same larger umbrella organization to, let's say, New Jersey, were being processed just fine. And so I would say take a closer look in the handling and then speak with your LabCorp or Quest representative and find out a little bit more about where specimens are being sent to, because there may be some nuances. There may be some nuances around that require a little bit of troubleshooting.
Okay, great. Thank you.
Yep.
Thanks. Are there any other questions?
Hi, this is Rachel. I wanted to just make a comment that one of the projects that we're doing as part of a state-funded hepatitis C testing linkages to care initiative is using public health surveillance data by looking at all of the positive hepatitis C antibody test results that come in through electronic lab reporting to our confidential morbidity reporting system to identify all antibody positive results that don't have a positive RNA, and working to contact the ordering provider to find out why RNA wasn't ordered. Sorry,
Sorry,
is it possible to mute the other line?
Dr. Sawarli, I think that is.
We might need to remute everyone and then take Rachel off mute so she can finish that thought. Sorry, everyone.
So Butte County Department of Public Health is doing a pilot project where they're using surveillance data to identify all people with a positive antibody who don't have a follow-up RNA test result. And we're really contacting the ordering provider to find out what's going on, and then working with them to see if it's possible to implement reflex testing. And so one thing that comes to mind is that if clinicians are in a setting where maybe you're not sure if your IT will be able to develop an algorithm to do that in-house, but if you live in a state that has electronic reporting, well, obviously in California we do, we may be able to work with the local health department of your county to give them a list of positive antibody and no RNA, and they could look at your clinic and see what's going on and which providers aren't ordering reflex testing and do some quality improvement there. Or you could just, skip to the chase and implement reflex testing, which is really a best practice. But I wanted to just let folks know that that's something that we're doing, and we're really interested to see kind of how that works out over the next few years as they implement that project.
Thanks, Rachel. That's exciting to hear about, and it'll be interesting to see what Butte County finds and to have that shared with folks like the folks on this call when that data is available. So if folks have questions, we'll come back to that in a moment. I just wanted to make a little pitch for a project that National Viral Hepatitis Roundtable, Project Inform, the California Hepatitis Alliance, and the California Academy of Family Physicians launched last year, which on World Hepatitis Day, which is July 28th. So coming up again this year, next week, which is a pledge that clinicians can take stating their commitment to screening their patients for Hep C in accordance with the United States Preventive Service Task Force recommendations. So you see on the screen the link to sign the pledge, an infographic that was developed that describes the issue, and a link to the USPSTF recommendations for screening. And so we encourage you all to sign the pledge if you haven't, and then your names appear on the side as sort of a free advertising for your commitment to the issue. And you know, depending on our time and resources, we may also try to have this list published in some medical publications in California, so that folks are aware of it and have a little peer pressure around the issue. So we encourage you to sign that. Are there any other questions? Since we have about 5 minutes, I would be curious to hear a little bit from, you know, I know Dr. Chuskin's done some work on this, and Dr. Kubota, if you have anything to add, but I know there was sort of this brief mention of kind of assessing patient readiness, and in terms of patients who inject drugs, you know, a real public health imperative to test and treat them, in addition to their personal health imperative of helping people have, you know, maximum health and be cured of a chronic disease. But I'm wondering if you could speak to some of the success that there's been around treating people who are actively injecting drugs, and some of the ancillary support and services that can underscore, you know, help to underscore that success, such as directly observed therapy and patient navigation and buprenorphine and methadone.
Sure, this is Stacy. I'd be happy to speak just a few moments on this. So we work very closely with our syringe exchange program, which is, they've been just extraordinary. It's Prevention Point Philadelphia. They have embedded testing there with reflex to confirmatory testing, as well as a navigator that actually attends all of our Hep C. We have a weekly meeting called a Hep C huddle. They come to every single week, and we make sure that we're sort of giving them, the patients that are referred to us through our syringe exchange program, multidisciplinary care and support, both through the on-site patient navigation that happens at Prevention Point, as well as through our patient navigator. So there's a really open collaboration between us all. And I have to say, you know, we practice a harm reduction model of care, where we just really meet folks where they are. And if they're coming in for their appointments regularly, they're engaged, they're wanting to be treated, we go ahead and we treat them. And of course, we give them intensive counseling around the possibility of reinfection. We talk about safe injection practices, and of course, if they're ready to stop or cut back, we try to provide them with support services to do that. We do use a modified DOT model, not just for our patients who are actively using drugs, but for all of our patients. We get our medication delivered to our practice through our on-site pharmacist, and for under the best case scenario, we don't give more than a month of medication at a time for many of our patients, particularly if they're homeless or we're concerned about them. We'll give out 1 to 2 weeks at a time using pill boxes and providing support. We have had, at times, if patients can't come to us, our outreach team will go in and bring medication to the patient if needed. And we try to couple them coming in for appointments with adherence visits, as well as medication, education, and lab work too. If patients can't get to us because of challenges around transportation, the on-site navigator at prevention point is also a trained phlebotomist, and so she has standing orders with us to get a viral load, CBC and CMP for anyone that can't make it in. And that way some of our payers require, like, insanely, so a week 2 or a week 4 viral load, which makes no clinical sense because it doesn't bear on the impact of continuing or stopping treatment, but they require it nonetheless. And to not have treatment interrupted, we make sure we get that blood work for our patients to demonstrate that they are in fact engaged. They just may not be able to make it across town to us.
Thanks, Stacey. I think that's helped. I think, there's kind of a myriad of types of patients who may be coming in for screening and treatment. And I think it's helpful to hear kind of one approach to working with patients who may be actively injecting or may have other kind of psychosocial issues that make, that have provide them with some competing needs and issues. We have, I think, 1 more minute if there's any last questions. Okay, so I want to thank everyone for participating in the webinar, especially thanks to our speakers who provided really helpful information and are all a wealth of information and great resources. So you'll see their contact information. I hope you'll be in touch with them if there's ways that they can share their information and expertise with you. And you'll get a follow-up email with the slides and a link to the webinar recording. And we also do encourage you to sign the Hep C Honor Roll Pledge and sort of help build the support, the vocal support of primary care providers saying that they're screening their patients according to the USPSTF recommendations. So I hope everyone has an excellent weekend.